welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
My name is Jamie Beck. I'm the PGY2 Emergency Medicine Pharmacy resident at NKC Health in North Kansas City, Missouri. And the journal we will be reviewing is Intravenous Tenecteplase before Thrombectomy in Stroke. Myself and those involved with this presentation have nothing to disclose. Our objectives for today will be to discuss acute ischemic stroke treatment options and to review the current literature assessing fibrinolytics prior to thrombectomy. This slide has some of the abbreviations that I'll use throughout the presentation. Management of acute ischemic stroke is timely reperfusion, as timely reperfusion is associated with more functional independence and less disability for our patients. Reperfusion modality is dependent on time of symptom onset or the time of last known well, as well as clot size and location. In the 2019 AHA-ASA treatment guidelines, IV fibrinolytics are indicated in patients who present within 4.5 hours of acute symptom onset. So the end of our coagulation cascade, thrombin mediated the conversion of fibrinogen to fibrin, which is then used to create a cross-linked fibrin clot. The mechanism of fibrinolytics is to degrade this fibrin clot. After administration of a fibrinolytic, endogenous tissue plasminogen activators, or TPA, are released into our circulation. These tissue plasminogen activators convert plasminogen to the activated form called plasmin, which is a proteolytic enzyme that breaks the cross-links between these fibrin molecules, ultimately degrading the cross-linked fibrin clot and promoting reperfusion to the vessel and damaged tissue. The two primary fibrinolytics, as you guys know, that are used in clinical practice are alteplase and tenecteplase. Alteplase was approved for acute ischemic stroke by the FDA in 1996 and has been widely used for this indication. Tenecteplase only recently received approval in March of this year for acute ischemic stroke by the FDA, but use for acute ischemic stroke has been slowly increasing over the past few years. Tenecteplase is a bioengineered variant of alteplase. It has an extended initial and terminal half-life compared to alteplase, meaning that it can be administered more conveniently as a one-time bolus instead of as a bolus followed by a 1-hour infusion, which is an obvious advantage. Additionally, tenecteplase is 14 to 15 times more fibrin-specific compared to alteplase, targeting more of the fibrin clot than exhibiting a systemic effect. IV fibrinolytics are indicated for acute ischemic stroke that causes measurable deficit or damage to the patient, whether it's present in a small or a large vessel. Large vessel occlusions often present with the textbook stroke symptoms that we learned in school. To be considered a large vessel occlusion, the luminal diameter of the vessel should be greater than 2 millimeters. Vessels that typically fall in this category include the intracranial internal carotid artery, the basilar and intracranial vertebral arteries, and the M1 segment of the middle cerebral artery. These vessels are typically defined in acute ischemic stroke studies and literature, but other vessels that can also be considered large vessel occlusions are the M2 segment of the middle cerebral artery, as well as the anterior and posterior cerebral artery. So if a large vessel occlusion is identified on CT head or CT angiogram and the patient's acute symptom onset is within the past 24 hours, patients may also be eligible for mechanical thrombectomy to restore perfusion. There's numerous mechanical thrombectomy techniques. I won't go too far in depth, but they're dependent on the clot size, location, and the interventionalist's overall assessment and comfort. Most commonly, though, they use catheter-based therapies such as stent retrieval, which is pictured on the far left, and then direct aspiration, which is pictured to the immediate right. So in patients with confirmed large vessel occlusion on imaging who present within 4.5 hours of symptom onset, there's an overlap between both reperfusion strategies. In this scenario, the 2019 AHA-ASA guidelines recommend that eligible patients receive IV alteplase even if mechanical thrombectomy is anticipated or planned for the patient. This practice is also supported by the Society of Vascular and Interventional Neurology Guidelines and Practice Standards, who published a 2022 brief practice update regarding IV fibrinolytics before thrombectomy in patients who presented with large vessel occlusion acute ischemic stroke. This was a meta-analysis that included 6 randomized controlled trials in patients that had emergent large vessel occlusion who were deemed to be eligible for both IV fibrinolytics and mechanical thrombectomy. Patients that were randomized to bridging received an IV fibrinolytic followed by thrombectomy and were compared to patients who were randomized to only receive thrombectomy alone. And their primary outcome was assessing the 90-day modified Rankin scale score of 0 to 2. So as a refresher, the modified Rankin scale was created to assess the level of disability after a stroke or other neurological episode. It ranges on a scale of 0 to 6, with 0 being no symptoms and 6 being death. A modified Rankin scale score of 0 to 2 indicates functional independence, and that's a very important endpoint in acute ischemic stroke assessments in literature. So again, a score of 0 means that there is no deficit, no disability. A score of 1 means that the patient has no significant disability despite their symptoms, and they can perform all of their activities of daily living, as well as the prior activities that they completed before the stroke. A score of 2 means that the patient has a slight disability, but they can still maintain their activities of daily living. Maybe they just can't perform all of the activities that they did prior to the stroke incident. A modified Rankin scale score of 3 means that the patient can perform most of their activities of daily living, but may need assistance with some of them. A score of 4 is severe disability, and the patient is restricted to either a bed or chair for a significant portion of the day. A score of 5 means that the patient is entirely dependent on a caregiver, and 6 is, again, death. So these 6 randomized controlled trials that they used for the meta-analyses was published between 2020 and 2022. All trials utilized Alteplase as the sole IV fibrinolytic except for Direct Safe, which did allow Tenecteplase but had an overall low number of use. So we can see here on the forest plot on the right that there was no significant difference in any of the trials or overall, which is represented by the red diamond at the bottom, that favored IV bridging with fibrinolytics before thrombectomy compared to just thrombectomy alone. We do see that potentially there is a trend, especially when looking overall, that a trend towards favoring IV bridging with IV fibrinolytics before thrombectomy, but again, not enough to be statistically significant. Next was the Extend-IA T&K trial, or the Tenecteplase versus Alteplase before thrombectomy for ischemic stroke. This was a multi-center, open-label, blinded outcome, randomized controlled trial that was conducted to compare Tenecteplase to Alteplase and establishing reperfusion in patients before thrombectomy when it was administered within that 4.5-hour symptom onset window. Their primary outcome was substantial reperfusion, which they defined as the restoration of blood flow to greater than 50% of the involved territory, or an absence of retrievable thrombus in the target vessel whenever they did the initial angiographic assessment. This occurred in 22% of patients receiving Tenecteplase and 10% receiving Alteplase. Their adjusted incidence ratio for superiority was 2.2, which was a statistically significant difference. Something important to point out is patients that did achieve substantial reperfusion for the primary outcome did not undergo thrombectomy in the Extend-IA T&K trial. For their secondary outcome of functional independence, this occurred in 64% of patients who received Tenecteplase compared to 51 receiving Alteplase, with an adjusted incidence ratio of 1.2, which was not a statistically significant difference. Again, their secondary outcome was functional independence, and we saw in the prior meta-analyses in all 6 of those randomized controlled trials, functional independence was actually the primary outcome, so just something to consider. And then for their safety outcome of mortality, this occurred in 10% of patients receiving Tenecteplase compared to 18 receiving Alteplase, with an adjusted incidence ratio of 0.5, again, not statistically significant. Other important things from the Extend-IA T&K trial is that around a quarter of patients in each group did require intra-hospital transfer to a thrombectomy-capable hospital. They did record the time from fibrinolytic to puncture, mechanical thrombectomy puncture in the patients both treated on-site and that required transfer. So patients treated on-site from time of fibrinolytic administration to puncture was 32 to 37 minutes, compared to patients that required transfer where it was 65 to 75 minutes. So although there was no difference between the arms for patients that required transfer or patients that were treated on-site, there was an almost doubling for patients that required transfer to a different institution. So gaps in literature are because the prior literature has primarily focused only on alteplase as the sole IV fibrinolytic, and the current guidelines don't review literature on tenecteplase for this indication or make recommendations for tenecteplase prior to mechanical thrombectomy, which led to the creation of the Bridge TNK trial, or intravenous tenecteplase before thrombectomy in stroke. The researchers aim to determine if IV tenecteplase plus mechanical thrombectomy would lead to increased functional independence, so that modified Rankin scale score of 0 to 2, at 90 days compared to thrombectomy alone in patients with acute ischemic stroke due to large vessel occlusion who presented within that 4.5-hour acute symptom onset window. This was an open-label, multi-center, randomized controlled trial that was conducted in 39 thrombectomy-capable hospitals, meaning that the study did not include any patients that required transfer to a different institution. It was conducted in China between May 9th of 2022 and September 8th of 2024. Because it was open label, that can introduce some bias, but they did blind the outcome assessments, including radiographic imaging and the NIHSS scores. Patients were randomized in a 1-to-1 ratio utilizing a fixed block randomization scheme. And again, because it was open label, patients and staff were informed of the treatment assignment after randomization. They included adult patients over the age of 18 with an acute ischemic stroke due to an internal carotid artery occlusion, the first or second segment of the middle cerebral artery occlusion, or a vertebrobasilar artery occlusion. Last known well had to be within that 4.5-hour window, and mechanical thrombectomy had to be planned by the care team. Exclusion criteria were presence of an intracranial hemorrhage, any contraindication to fibrinolytics, which are similar to the contraindications we use. They had received fibrinolytics prior to randomization, and if the patient was pregnant or breastfeeding. Patients randomized to the bridging arm received IV tenecteplase at 0.25 milligrams per kilogram with a maximum of 25 milligrams and were followed by mechanical thrombectomy, which were compared to patients who received rapid mechanical thrombectomy alone. Their primary outcome was functional independence at 90 days. Secondary outcomes included the 90-day modified Rankin scale score, health-related quality of life questionnaire scores, and successful reperfusion both before and after thrombectomy. And they defined successful reperfusion in this study as an expanded treatment in cerebral infarction, or the ETK grade of 2B, 2C, or 3, meaning that they had demonstrated reperfusion of 50% or more of the affected territory. They had near complete reperfusion with a distal slow flow, or they had complete reperfusion. Their safety outcomes were 90-day mortality, the presence of intracranial hemorrhage at 48 hours, and then the presence of symptomatic intracranial hemorrhage at 48 hours. The main analysis was performed using an intention to treat population. A Poisson regression model was used for the primary outcome and all binary secondary outcomes to generate an adjusted risk ratio. The treatment effect was adjusted for pre-specified covariants, including age, NIHSS score at baseline, the site of occlusion, the time from last known well, and then the aspects, or the Alberta Stroke Program early CT score at baseline, which the aspect score is used to measure the extent of early ischemic changes, and it helps dictate mechanical thrombectomy recommendations. They did calculate an anticipated effect size of 13%, or a 13% difference between the groups for the primary outcome, and at 80% power calculated they would need 462 patients. 554 patients were randomized, 4 patients withdrew consent, leading to 550 patients being included in the intention to treat population. Here we can see that there were no significant difference between baseline patient characteristics. The median age was 70 in both groups, primarily male. The pre-stroke modified Rankin scale score was 0 in 95% of patients in both treatment arms. And the middle cerebral artery was the primary occlusion site for the majority of patients in both arms, followed by the internal carotid arteries and the vertebrobasilar arteries. Additionally, systolic blood pressure was similar between the groups in the 140s, and the NIHSS score was 16. From last known well to randomization, again, not a significant difference. So in the IV bridging group, this was around 160 minutes compared to 168 in thrombectomy alone, so both a little less than 3 hours. From randomization to receiving IV TNK was 6 minutes in our bridging group. From IV TNK to puncture was 16 minutes, again, in our bridging group. And then from randomization to puncture was 28 minutes in the bridging group compared to 24 in thrombectomy alone, so only a 4-minute difference there. And from puncture to successful reperfusion was 55 minutes in the bridging group compared to 64 in thrombectomy alone. Again, not a significant difference, but we can see that numerically it was about a 9-minute difference. Regarding their primary outcome of 90-day modified Rankin scale score of 0 to 2 or functional independence, this occurred in 53% of patients in the bridging group compared to 44 in thrombectomy alone. Their adjusted risk ratio was 1.18, and this was a statistically significant difference. We can see here that the effect size was slightly lower than their anticipated 13% and instead was 8.8%. And overall, with the results of their primary outcome, the number needed to treat for benefit was 11. Their secondary outcome of 90-day modified Rankin scale score of 0 to 1 occurred in 35% of patients in the bridging group compared to 28 in thrombectomy alone, which was not a significant difference. For scores of 0 to 3, this occurred in 64% of patients in the bridging group compared to 62 in thrombectomy alone. Again, not a significant difference. Regarding their definition of successful reperfusion before thrombectomy, there was a statistically significant difference, which is to be expected because our bridging group did receive a reperfusion modality prior to thrombectomy. So that occurred in 6% in the bridging group compared to 1 in thrombectomy alone. And then for successful reperfusion after mechanical thrombectomy, again, not a statistically significant difference, but 91% in the bridging group compared to 94 in thrombectomy alone. This is another visual of the modified Rankin scale score for these patients and the distribution. So at the top is our bridging group, and then the bottom is thrombectomy alone. Lighter colors represent lower modified Rankin scale scores. So we can see that a score of 0, 1, and 2 had a higher distribution in the bridging group compared to thrombectomy alone. And we can see that that distribution kind of closes the gap for higher scores of 4, 5, and 6, where they're similar between the two treatment arms. For safety outcomes, they assessed 90-day mortality. So this occurred in 22% of patients receiving bridging compared to 20 receiving thrombectomy alone, which is not a statistically significant difference. Patients with incidence of intracranial hemorrhage within 48 hours was similar at 31 to 32% per group, which was not a significant difference. And patients with symptomatic intracranial hemorrhage within 48 hours was 9% in the bridging group compared to 7% in thrombectomy alone. Again, not a statistically significant difference. They also performed a subgroup analysis for their primary outcome, which was functional independence at 90 days. So I have the forest plot pictured to the right. Again, statistical significance was seen overall for all patients that were enrolled and randomized in this trial in the intention to treat population. They also found significance in patients with an aspect score of 8 or less at baseline, with lower numbers being more significant ischemic territory. Also found significance for patients whose stroke was deemed to be due to cardioembolic source, for patients whose last known well to randomization was 163 minutes or greater, and then patients whose last known well to start of IV Tenecteplase was greater than 140 minutes. So the key takeaways from Bridge T&K are that patients receiving Tenecteplase prior to mechanical thrombectomy had increased functional independence at 90 days. They had no difference in successful reperfusion compared to patients who received mechanical thrombectomy alone. And they had no significant delay for mechanical thrombectomy. If you recall, it was 28 minutes compared to 24, so only a 4-minute difference from the time patient was randomized to thrombectomy puncture. Other things to consider is that time from IV fibrinolytic administration to mechanical thrombectomy puncture was 16 minutes. Again, remembering that this was only including hospitals that had thrombectomy capabilities and did not have any patients who transferred. So strengths are that this was a randomized controlled trial. It was open label, which does introduce bias, which is a limitation. However, they did try to adjudicate the outcomes by a blinded committee, again, with the imaging and NIHSS scores. Limitations are that they excluded patients that would need inter-hospital transfer and did not include any of those institutions, which is a limitation because now it's less generalizable to hospitals that are not thrombectomy capable, including the institution where I'm training at. as well as their effect size was smaller than anticipated. Again, 8.8% is what they found compared to 13% is what they anticipated. So they likely didn't keep conventional power, and potentially if they had reached their desired effect size or if they had enrolled more patients, potentially there would have been a more profound difference between the groups. So in conclusion, from Bridge T and K, Tenecteplase is an appropriate alternative to alteplase for bridging prior to mechanical thrombectomy. And as more literature comes out and the guidelines become renewed, I would anticipate seeing this as a recommendation in the guidelines. And I would also recommend that future trials include non-mechanical thrombectomy capable hospitals to allow for more generalizability and allow for subgroup analyses, because that's a large question in these institutions is, should we administer IV fibrinolytics before transferring them to a thrombectomy capable hospital? The RELIANCE Direct T and K trial is a multi-center, double-blinded, randomized, placebo-controlled trial that's currently enrolling patients that's aimed at answering the same exact question as Bridge T and K. The study completion is anticipated for 2027. It is a double-blinded, placebo-controlled trial, so one treatment arm will be IV fibrinolytics, including Tenecteplase plus mechanical thrombectomy, and will be compared to placebo plus mechanical thrombectomy alone. So the results from this trial will be interesting to compare to Bridge T and K, and also add to it to see if there's any specific subgroups that either benefit from IV fibrinolytics before thrombectomy or potentially have harm from it. These are my references. I'd like to thank my program director, Megan Musselman, for precepting me on this presentation. And that was all I had, so I will now take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.